I'm Sarah Norcross and I'm the Director of PET, Progress Educational Trust, an independent charity which aims to improve choices for people who are affected by infertility and genetic conditions. Careful what you look for. What should we be looking for in sperm and egg donors? And we're very grateful to the Scottish Government who are supporting this event. And so before someone can become a sperm or egg donor in a clinical setting, they usually have to meet certain criteria and undergo various tests and checks. And this is to increase the chances of assisted conception being successful and to reduce the risks to the health of the resulting donor-conceived child and recipient. And in the UK and elsewhere, professional bodies have drawn up guidelines for screening donors, and these guidelines are revised periodically in line with the latest evidence and thinking. However, some clinics and services might choose to employ additional tests on top of those. And one important way of assessing donors is carrier screening. And traditionally, carrier screening was performed for one gene at a time and offered for genes strongly associated with severe conditions that either present from birth or manifest during childhood. However, in 2010, so-called universal carrier test became available. And for the first time, this ushered in a sort of new era of expanded carrier screening. And this involves identifying simultaneously the presence or the absence of many gene variants, which might be associated with a vast number of different conditions of varying severity and predictability. And unlike traditional carrier screening, expanded carrier screening does not have to be guided or constrained, I suppose, by a person's individual or family medical history. And as expanded carrier screening makes us question, what is it reasonable to screen for or not to screen for? And in a public healthcare system, what are the cost implications of screening or not screening? And given that practically everybody is a carrier of at least some disease-related gene variants, does expanded carrier screening threaten to exclude most or perhaps all potential donors? So it's getting to be quite enough from me now. So we're going to hear tonight from Professor Zosia Miedzybrodzka. I hope I've got that right. Professor Scott Nelson, Dr. Véronique Berman, and Professor Guido Pennings. They're all going to give a presentation back to back, and after that we will then have the questions and answers with the panel.
Thank you for listening. So I was given the remit to give you some genetic background about extended carrier testing. And so I've entitled this, I started by calling it Careful What You Wish For, which was an accident, but it kind of, I think, maps onto the sentiment. I've been asked to do a quick summary of the genetics involved, and just to put some points across in a very brief piece of time. So forgive me if I skip over things you'd have liked me to explain a bit more, and I can expand on that later. Just to make sure everyone's up to speed, our bodies are made of cells. Each cell contains a full set of DNA recipes or instructions to make every protein, which is what our body's made of. The DNA we get from our parents. We get half of it from our mother, half of it from our father, and it's stored on things called chromosomes. And that a chromosome is just a coil of DNA. So for the vast majority of things we're talking about today, we're going to be talking about problems caused by, in each individual person with it, perhaps one rung of the DNA ladder going wrong, or a piece missing, or a chunk missing in both copies of the gene. And that's something we call autosomal recessive inheritance. And it's shown here where typically you would have a father who has a normal copy of the gene and an altered copy of the gene. And that father gets enough of the right protein from his normal copy, so he's completely unaware of being a carrier. Likewise, mum has a normal copy and a faulty copy, but if they meet up and they both have alterations in the same gene, then they have a 1 in 4 risk in each pregnancy of having a child that's affected by the condition, and a 3 in 4 chance of having a child that's unaffected, although some of the children might be carriers. So most of what we're talking about today is recessive disease, though there are conditions that could be caused by changes on the X chromosome, which can only be inherited from the mother. We've spoken a little bit earlier about, well, who should you test for? The question then, if you start testing for things, are we going to test for just childhood onset conditions? Are we going to test for adult onset conditions? I think most people agree we should test for serious stuff, but then what counts as serious? I have patients who have a condition called Huntington's disease. Many of them will live 50 or 60 years of normal, happy lives until the condition finally starts to affect them. Should we be screening for things like that? If we screen for that in a child, then you might, in the parent, are they even aware of it? Should we be looking at things like that? Should we, what if we find out that the donor actually has a disease, that they were just being tested for a carrier and they were just giving a donation anyway? They didn't really kind of sign up to that. So we need to think about those things. I think the background of this is probably, the majority of couples will wish for a healthy, normal baby. But I think it's worth reflecting on what the chances of somebody having a baby with a serious medical problem are. So this is data from Scotland, just in the latest data that's available, which is from 2017, from our very new CARDRIS survey, which is, it was a real step forward to get this data. But what you can see here is that for every 10,000 births in Scotland, something like 80 children have got a congenital heart defect. Nervous system defects are quite common, and so on. But what we've got here is the proportion of severe abnormalities which are caused by known genetic stuff. And as you can see looking at it, the light blue, there isn't a lot of it. So we have to start this conversation saying, well, actually, first of all, most of the malformations, most of the serious problems affecting children don't have a genetic basis we would be able to detect. So that's my first point. Reflect on that a bit further. This is Down syndrome. It's extremely variable. You get very severely affected children with profound learning disability, and you get children with Down syndrome who grow up, adults who have very full lives. And, is this something you would want to look for or not? This is probably one of the commonest congenital disorders that we know of. You wouldn't be able to screen for this one because the child is almost always the first one in the family with it. So you wouldn't get this one. And then think a little bit more. Well, you might say to me, well, let's just test all of somebody's genes. Well, we could. Cost about £7,000, but we could. But if we do that, we find over 6 million variants in everybody's genome, of which about 600,000 are rare, and 2,800 or so will change a protein. So that means that most people are carriers of something like 2,800 different things. Now, that maybe only matters if both parents are carrier of the thing, but this shows the amount of effort that needs to be gone into analysing a genome when you've got a child with a disorder. If you then extrapolate that to carrier screening, it could be more complicated. So how well does that work in practice? We need to also think about there are other ways that genetic diseases can happen. This is for the nerdy people. I can come back to these later if you want. But basically, I think the main point I want to make here is that at least 42% of children with severe or profound learning disability, they are the first one in the family to get it. Their parent has normal genes, and the child has a mutation in their creation. So much of the problems parents would want us to screen for are not detectable. Okay, well, let's look for what we can look for. And this is just some early results from using extensive carrier testing in detail rather than focusing in on common gene alterations which are known to cause things in families. So when they did this test on about 11,000 people, they found that 1 in 4 people were carriers of something, which is quite a lot. Of course, it only matters, though, for their offspring if the other partner is a carrier of the same thing. That wasn't in the paper. But let's just look at the rates. So I've underlined here 2 conditions where the rate in the general population was less than 1 in 100. And in fact, only one of them, cystic fibrosis, is common enough to meet the bar for the testing that we would be able to offer family members under current Scottish guidance. So, yes, 1 in 30 people are carriers of cystic fibrosis, about 1 in 93 Tay-Sachs disease. This was an American study, probably the rate in Scotland is less. And there are other things that might be more common in Scotland. And this doesn't mention sickle cell disease or the blood disorders, thalassemia, which I would probably include here. But you might then say to me, well, why not just test for them? So just take that example of cystic fibrosis and just thinking about the context of this. There's about 6,000 bases of the DNA ladder for cystic fibrosis and over 1,700 different mutations that could cause that disease. 30 of them would be tested for in sort of standard expanded carrier tests. So what do you do then if you find one in 4 of your donors has got a CF mutation? They've got a CF mutation. What are you going to do? Are you going to test the recipient? Are you going to test the recipient for 1,700 gene alterations or just for the common 30? Because you might miss something, but then it costs more to do the 1,700. And then what about the rest of the family? Do you then go back to the donor and say, well, if you're having more children with your own partner, would you like them to have a test? And should they get the 1,700 or just the 30? And then the donors will have brothers and sisters. And are you going to offer the test to them? Now, at current levels of funding in NHS Scotland, we only offer carrier tests for recessive conditions where the frequency in the population is greater than 1 in 50 and there's a common mutation of disease-causing potential that's well described that we can test for. So if you took that approach, at most, you would come down to cystic fibrosis, spinal muscular atrophy, sickle cell and thalassemia disease, and Tay-Sachs disease. We maybe Tay-Sachs disease in certain ethnic groups. So the other complexity we have here is that if you test lots of gene alterations, then we run into the problem of whether a difference in a gene is truly disease-causing or it's not. And would you want to not use someone as a donor who has a variant in a gene which may or may not cause a disease? If 1 in 4 of them have got that, you're not going to be left with many donors. Or do you say, well, you should use the donor and just test the partner? I'll hand that over to the rest of the team to discuss. Thank you.
For those of you who don't know who Zosia is, she is Professor of Medical Genetics and co-director of the Centre for Genome-Enabled Biology and Medicine at the University of Aberdeen and Service Clinical Director of Genetics at NHS Grampian and former lead of NHS implementation at the Scottish Genomes Partnership. So you can see why we chose her to introduce this and give that very clear presentation setting the scene. Now, our next speaker is Scott Nelson, and I'm not going to forget to introduce you, Scott. So Scott is Professor of Reproductive and Maternal Medicine at the University of Glasgow and a specialist in reproductive medicine at Glasgow Royal Infirmary's Assisted Conception Service and also at the Glasgow Royal Fertility Clinic. So I'm going to disappear and mute myself and I'll hand over to you now, Scott.
Thank you very much. So it's a real opportunity to think about expanded carrier screening, and what I probably put it to you is it's time to embrace it and move on. So population-specific carrier screening programs, essentially there's 2 big examples of that. The first one is beta thalassemia, and you can see here that we know that the prevalence of that population depends on where you're from within the world. So this is data from Sardinia when they started to do testing, and the impact that they had. So they went all the way from 10% down to much smaller number of affected infants being produced. The Jewish population also recognised the problems that they had with the Tay-Sachs disease, and they've taken novel, innovative approaches to that. So much so that there's the Dor Yeshurim Society, which is the whole basis there, is preventing tears, as their logo says. But it was built on that premise of preventing and debilitating recessive disease. And we can perhaps talk about how they've done that. And there's even a UK equivalent of that, genetics. But what I would take from these kind of two big programs is that autosomal recessive conditions are more common in certain populations, of that there's no doubt. And targeted prevention strategies can be developed and are acceptable to, to patients. The decision for reproductive alternatives rests with the individuals concerned. So there's different pathways now, particularly with now they've got pre-implantation genetic testing. And actually extensive educational projects and generalisation of testing completely destigmatises carriers. And that's what we've seen with the beta thalassemia and the Tay-Sachs. So when we start to think about beyond that, actually that's where we need to get to. So what's the burden of recessive diseases? Zosia has presented some Scottish data from 2017. There's about 50,000 births in Scotland per annum. To put that into context, this is data from my Baird and colleagues with more than 1 million births. And what they were looking at was what's the chances that that is due over the first 25 years of life, reflecting that it's an autosomal recessive condition or dominant. And you can see that it's about 1.7 per 1,000 neonates. But we know that that's going to be higher depending where you live. For example, if there's an evolutionary advantage, as we saw, for sickle cell in terms of malaria, it can be 10 to 20 per 1,000. And if there's evidence of endogamous society or consanguinity, it can be higher again. So about 7 per 1,000. So endogamous is where you measure marry within your society, like the Tay-Sachs for the Jewish population. So these are examples of kind of how prevalent it can be. And Zosia said, well, there's a small fraction of these were genetic. But what we didn't know is what proportion of all those other conditions were also genetic, because actually none of those people got sequenced. So when it looks at £7,000, I'd probably say, why do we not spend £7,000 trying to get the right diagnosis for patients? So how many autosomal recessive genes are there? Well, today, I checked today, in the clinical genomics database from NIH, there's 2,114 autosomal recessive genes listed. But this paper, kind of in human mutation, suggested, looking at consanguineous, where there's 2 affected individuals, that perhaps there was 5,000 recessive human phenotypes. So many more than we're already aware of. But it's a bit more complicated than that, and Zosia is much better placed to explain this than I am. But in terms of haploinsufficiency, when we think of all the genes, so there's a degree of loss of function intolerance with that. And we can think of that spreading out in terms of autosomal recessives. And when this was done, there was only 1,727 listed for autosomal recessive rather than the 2,000 that there is today, and autosomal dominant. So again, being able to cope with that loss of drop-off of one of those alleles. And you can imagine that that is much more evident in autosomal recessive conditions. But if you take that and you do the maths, you end up with probably about 9,000 to 10,000 autosomal recessive clinical phenotypes. So a huge number that we're just not diagnosing. Some of those might be extremely mild, but there's a vast untested and unrecognised autosomal recessive conditions. So going back to that kind of question about ethnicity, and this is just one of those panels, and we'll talk about the variety of the panels and the size of the various panels that you've got available to you. But this was looking at 417 disease mutations, so just 108 conditions. So if we just talked about 2,000, 5,000, or even 10,000, this is only looking at 108. And it showed that probably for Northern Europeans, so like myself, there's about 3.8, 1 in 4 of us has those in terms of being a carrier for one of those conditions. And when you started to look at more than that, so 2 or more disease, well, probably 19% of us have that. But I say that's us just looking for 108. If you start to look at 1,800, it's going to be, or 2,000, it's going to be at least 20 of these disorders or traits. But what would it be if it was 10,000? Even many more. But we start to be able to get a reason as to why we've got some of us are perhaps getting conditions. And inevitably, Rowan Wright and colleagues summarised this looking at a systematic review. The more that we test, the more likely that we're going to identify that. So as you can see, the chances that we'll be a carrier for something, it's not surprising. The more that we test for, the more likely we identify that. And similarly, the more that we test within couples, the more likely that we're going to see that they are both carriers for that condition. And you can see this clustering, down about the bottom left-hand corner here, where often we say 2, 3, 4%. And then there's this obvious outlier at Punj and colleagues out there. And I'll come back to that paper because I think that might be where we're going in the future. So what is the risk of pregnancies? At present, this is the biggest study that's been done. It published in JAMA in 2016, almost 350,000 individuals looking at 450 pathogenic variants, 94 genes. And what it showed was about 1 in 628 could be having a profound or severe condition in terms of that. And what that meant was that when you compared it, how it compared to using conventional screening for what we do, think about ACOG, so the American College of Obstetricians and Gynecologists, or the American College of Medical Geneticists panel, which is slightly different, actually, by just not ignoring those completely, not having to do any clinical history, and just going for expanded carrier screening, you improved it dramatically. You got a much better detection. Didn't matter which ethnicity you were, you actually got an improvement in your overall outcomes. And as we move towards a much more multi-ethnic population, and actually not sure as people are much more mobile and across relationships, why would we be trying to think about where are you from? Actually, why don't we just use a more genetic and scientific based approach? So that's kind of the case for expanded carrier screening. And you can see when you're doing it in 350,000 people in the US, it's already well accepted technology, but it's not so much so for donors. But why not? Well, perhaps there's 3 things that we need to think about for donors that I want to spend some more time on. The first is consanguinity, so the chance that you are related to that individual. So when we use donor banks, we don't necessarily know whether or not we're related to them. People often joke about non-paternity, but actually we might be closer than we think to the people that we're using as donors. And first cousins share on average about 1/8 of their variants, uncle-niece pairs about 1/16, and second cousins about 1/32, and third cousins, which is almost equivalent to being unrelated, is lower again. It's about 1 in 100. So if your carrier frequency is about 1 in 100, the chance that 2 individuals who are unrelated having, the same thing is 1 in 10,000. But essentially, if you're first cousins, it's about 1 in 800 because of that 12 times frequency. So what that means is that if your parents are first cousins and the heterozygous frequency is 1 in 100, the likelihood of having an effective offspring is only 3 in 10,000. So that's incredibly uncommon. But that's only for one condition. So yeah, reality is we've been talking about many more, these small panels being 100, potentially 2,000 conditions, all the way up to 10,000. So let's model that a bit more assessment. So let's taking that data of 1875, which is when what was available at this time as being autosomal recessive, and we say for those top 10 disorders about 1 in 50, which is probably about right. For the next 100 disorders, about 1 in 100. And then 1 in 200 for the next 500 disorders, and 1 in 300 for the rest. Yeah? So there's a varying gradient of carrier frequency there. And when you do that, what you recognize is that for the chances of having affected offspring with an unknown autosomal disease within that 2,000, if we tested them all, for an unrelated couple, it's about 2.5%. For a couple of second cousins, 6.9%, and first cousins, 22.6%. So at Glasgow Royal, we have 1,000 IVF cycles per year, 400 babies approximately born just from those fresh cycles. And reality is that perhaps we're creating 10 babies every year that have got an unknown autosomal recessive condition. Some of those we'll detect and we know about, and then others we don't. And it's not until later on if they had that, because they might have a very mild phenotype. But it's worth bearing in mind, and actually where within that spectrum and relationship status would be the donors. Are they going to be completely like those third cousins, or are they going to be closer to that? We just don't always know. Secondly, is the disease severity. And I think, Zosia gave a really kind of nice introduction to this, because there's real lack of agreement on what we classify as severe or profound. And in reality is that patients haven't been involved in these discussions. What you and I may think of as being a severe and profound actually can be completely different perception for patients. their disruption to their lives and what they've seen with one child being affected, or they're aware of cases, they might say, well, actually, I don't want to try and avoid that if at all possible, despite the fact that we might perceive it overall as mild. And they've not been involved in any of these discussions. So this is a new panel from Council. It's got 220 autosomal recessive conditions and 14 X-linked, and it's been validated in our ClinChem paper. So I think it's that evolving. So they went from 90 up to 220, and again, that's now what's being available. And then the last point that I really want to talk about was thinking about those unknown variants of unknown significance. And where do we put them within this spectrum that we can see here? Do we think about them, taking them all being, pathogenic by computational analysis, which is one extreme, but we might have false positives? Or do we go all the way through to the other extreme, where we think, no, they're only false negatives, and actually only take the known pathogenic variants that we know today, accepting that that might change tomorrow or the day after? Or do we try and go somewhere in between? And again, it's probably bringing the medical community together to think about how we do this is probably the key for moving forward. But we've got somewhere to start for just now. So why should we do all of this?
Scott, sorry, you're sort of getting really now on the end of your time. So
okay, yeah,
wrap it
almost
up quite quickly, please. Thanks.
Yeah, sorry. So the expanded carrier screening we can do by whole genome, and it's just to show you this. This is how using whole genome sequencing we do 728 plus 148 conditions, and we can do this. This was done through NIH, but what they identified was that 78% of the participants had at least one positive carrier result, and 16.9 were identified for a common condition. So for the NHS, the benefits are clear to me that, it's financial. So here's an example of cystic fibrosis costs. Annual cost, 48,000 per annum. The average lifespan of cystic fibrosis is 41. So probably today it's over £2 million for just cystic fibrosis. And this is an example for parents. We can prevent, difficult decisions, low risk of having with medical conditions. So you think of here, this proband that's got factor 5, 7 here. But before we went on to do pre-implantation genetic diagnosis for monogenic disease, we also did expanded carrier screening, and we saw that both of them had cystic fibrosis, as well as being carriers for this. This mum had already had prenatal diagnosis and termination of pregnancy as well. So you do this, you can see that there's those 4 embryos that were not affected in terms of that factor 7 gene. But from those, 3 of them were not affected for cystic fibrosis, but actually only one of those was suitable because they actually had trisomy 16 and trisomy 13. So from that, that's why we got a healthy individual with no genetic diseases. And that alone makes it worthwhile. So putting this in the donor program, I'm very conscious of the time sort of overrunning. When you think about how we do this for sperm donation, actually we have a really limited selection criteria. We've got, we put in a 6-foot, brown hair, brown eyes, fair skin donor, and that automatically rules out, the ginger hair, Glaswegian, and the, blonde, Danish person, and leaves 5. But if then you apply your expanded carrier screening, well, actually what we potentially do is leave out another 3 individuals, and you've still got a choice of 2. But if you're prepared to do pre-implantation genetic testing, actually you can bring back in 2 of those individuals, and you could use, any one of those 4. So perhaps we've got this all wrong. Perhaps we're focusing on doing this, at preconception, but actually we could do this much earlier in the process. And, Rowe and Wright have summarised where we can do it at any point across the lifespan, having expanded carrier screening. And perhaps that's where we need to move to. So to conclude, and I apologise for the time, autosomal recessivities are incredibly common, identifiable, and I would put to you also preventable. I don't think we should no longer be debating about whether or not we should be doing it, but we should be debating about what diseases to include and how do we manage the flow of information. And Guido is probably expertise in that. We're looking forward to hearing from him. Risk mitigation strategies are feasible, and PGTM can ensure that we do not preclude specific individuals from having treatment because we can use PGTM and we use it on a daily basis. And I'll leave you with one lasting thought when you say, perhaps when we're going about this, is how would you respond to the question when you're presented with that affected offspring, could we have done anything else to prevent this?
And so next up now we have Dr. Véronique Berman, who is the Scientific Advisor and Community Development Manager at Chana, a charity which supports couples with fertility problems in the Jewish community. And previously, Véronique was a senior scientist at Hammersmith Hospital and at the Royal Free Hospital in London.
Thank you very much indeed, Sarah. And thank you ever so much for the opportunity to take part in this very important conversation. I'd like to really preface my remarks also by thanking everybody at Progress for the tremendous work that they're doing, and especially for the enormous efforts that have been going on during the last few months during the COVID era to help and support the fertility community. Today we have a very specific conversation, and I'm very grateful to take part in it. I'd also like to thank my previous speakers. I'm not sure why. There we go. For introducing some of the ideas and setting the scene, which is most helpful. So by now you all know about genes, and you know how genes work, and the fact that we have 2 copies. And of course, that's a very important part of the conversation, because in each cell, part of the material comes from mum and part from dad. And as has been said and stated, we all carry some faulty genes, and we're focusing really specifically on recessive genes. And the important part about that is that if there's one copy that's faulty, that it's carrying a mutation, the fact that there is a second copy available, this will compensate for it. And so the individual who's carrying this trait will be blissfully unaware of the fact unless they go for screening, unless they are made aware of this. Of course, dominant genes don't work in the same way. There's no compensation. A faulty gene cannot be compensated for by the other copy. What is really important, and of course coming from the Jewish community is something that we are very much aware of, is the fact that some faulty genes are more common in certain populations, and we don't have the monopoly on this, as both previous speakers have mentioned. There are other groups that have specific mutations that are more common in their setting. So what are Jewish genetic disorders? These are genetic disorders that are common to Jewish ancestry. And what's important to have in mind is that they're not exclusive, as you've seen from the lists shown in the previous presentations, but there is a higher risk. And the other point to make is that it's about ancestry. It's not about the way of life or observance or what anybody's actually practicing in their day-to-day life. It's about their ancestry and their genetics. And the other thing that's also important is that people have the ability to screen, and they have the opportunity to take stock of what their genetic makeup is. And I just want to give you an idea of genetic disorders and look at the incidence of these in the Jewish population in comparison to the UK-based population. You've seen some of these listed on the other slides. You saw cystic fibrosis, you've already seen Tay-Sachs, but you can see how the numbers do compare, and there seems to be higher incidences of these specific mutations, particularly in this cohort, in comparison to the general population. So it's thought that 1 in 5 Ashkenazi Jews, that's Jews of Eastern European descent, will be carriers of at least one of these Jewish genetic diseases. They're rare, and as you've heard before as well, they're usually de novo. There's often no family history. The screening and why do it is really important, because it identifies those that are at increased risk, and it allows them to consider their options. And of course, as Professor Nelson just very clearly highlighted, gives the opportunity to avoid the risk of having an affected child. The options that couples who know that they are carriers face, they really have quite a lot of options available to them, but none of them are easy necessarily to contemplate. They can play reproductive roulette, which is just choose to take their chances. They can use donors, and of course that's a very important part of this conversation. They can choose not to have children or to adopt children. They can choose to avoid marrying somebody who they know is a carrier of the same recessive disorders that they are carrying. Or they can use other methodologies like prenatal diagnosis or pre-implantation genetic diagnosis, whereby they both know that they're carriers, but they do go ahead and screen the embryos to avoid having children affected. As you saw, the 1 in 4 chance of having an affected child if both members of the couple are carrying the recessive disorder. I'm using the Tay-Sachs disease as a proof of principle, as an example. You have heard it mentioned. It's a devastating disorder, and it's very much more prevalent within the Ashkenazi Jewish population. And before steps were taken to screen within the Jewish community as early as the 1970s, there were up to 60 diagnoses a year in the American and Canadian Jewish communities. So this is a very, very significant issue. In 1983, Dor Yeshorim, you've heard mention of that, was set up in America, although they do now operate worldwide. They screen in 11 different countries worldwide, was set up as a premarital and anonymous carrier screening program. And I highlight that because that differs to Genetics, which is the other organization, which is actually a UK-based organization, who operate very differently. But the bottom line of the way the two organizations offer is that they offer carrier screening to young adults, very often long before they're thinking about conception. They actively go out to universities, to high schools. They encourage within the community setting young adults to be screened, in many cases long before they're thinking about parenting, but that these couples these individuals should be aware of their carrier status long before they become couples, and then can face the choices, but very much with the knowledge of what their status is ahead of time. Today, those options remain, and there's a lot of activity within the community encouraging individuals to have a clear understanding of their genetic makeup. Tay-Sachs screening, for example, is available in the UK on the NHS, and the genetic disorders are screened for, and if individuals use Dor Yeshorim, this is done in complete anonymity. So they will send their blood sample away, they'll be given an accession number, they'll never be given the data, and they don't know what they're carrying or if they're carrying anything at all until such time as they meet a match and they wish to marry someone, and then they'll check the two accession numbers and see whether or not they are deemed to be a genetic match or not. Genetics operates very differently. An individual will go along for screening, be sent a printout. Important to note that both these services are accompanied by genetic counsellors. They're accompanied by implications counselling, so that the individuals undergoing the screening have a clear idea of what they're letting themselves in for. So to address the question that we were asked is what you look for, based on the experiences of the Jewish community and almost 40 years of experience whereby we've seen how the screening can lead to almost complete or significant eradication of a disease like Tay-Sachs through active programs of screening, the choice needs to extend to the donor gametes, specifically for the couples who know that they are carrying Ashkenazi mutations. They're choosing to use a donor in many cases because they are both carriers, and therefore it is imperative and probably foolhardy for them not to request that their donors be screened as well. So I will leave the conversation open, and thank you so much for your attention.
So last but by no means least, we have Professor Guido Pennings. And so Guido is Professor of Ethics and Bioethics at Ghent University, and he's the Director of the Bioethics Institute, Ghent. So I'll hand over to you now, Guido.
So good evening, and thank you for the possibility to clarify my position in this. If you wait a minute. Yep. So I would like to broaden the question about donor screening, because I've been looking at the literature, and especially at what is happening a bit worldwide, both in fertility clinics and in egg and oocyte banks. And what I see is that increasingly these banks and clinics are asking or requesting the gamete donors to submit to expanded carrier screening. And this includes very frequently hundreds of diseases at the same time. So my question, especially as an ethicist, is what exactly are we doing this for? And the general answer there is relatively simple. We want to reduce the risk, the genetic risk for the offspring. And the question then, in terms of proportionality, is whether the benefit you make in that regard is compensated by the harm that can be done to the gamete donor. Now, you should know that, and in fact, it was also mentioned by the previous speakers, that these diseases are in general very rare. And the total risk reduction when you apply expanded carrier screening panels is below 1%. Now, this is in fact a very small gain. And especially when you take into account the fact that there's still the residual risk, as was mentioned by the first speaker. So the question then is, if this is the case, then what other reasons can explain the push you see now for expanded carrier screening? I think there are two things which are very important in this regard. The first one is that gamete donation is increasingly seen as a commercial service, and recipients want to have high quality material. Now, the conclusion from this position is that the more screening, the better, because that in fact guarantees the quality of the material. Secondly, gamete donors are seen as providers of material that are being paid for their contribution. So when you look at this within the whole setup, they are looked upon as second-class participants in the sense that their interests are not put first. They are expected to do what the recipients want. And of course, the recipients want to have a zero risk. So the conclusion is that, and this is in itself already quite remarkable, is that the freedom to decline genetic testing that is strongly defended for infertility patients and for the general population is readily denied to gamete donors. And this is strange and should be, in fact, explained. Now, donors have the same possible social and psychological burden as any other person who would be having preconception expanded carrier screening. However, there's one important difference. First of all, the donor is not asking for information for him or herself. And secondly, the donor is in a completely different mindset, meaning that the donor has no intention to conceive. Now, this is an important point because obviously when you do the counseling, you try to do the counseling in the appropriate way. And in this case, it's going to be very hard for someone to really understand what the implications would be of the information that might be obtained through the expanded carrier screen. And also remarkable, and again, you just have to look at the literature, is that there is no information available on the information management. For instance, what are the donors told about the results? Will the donors be informed about variants of unknown significance? Is this something they're going to find out? What about incidental findings? No information whatsoever. To what extent do the donors have a say in what information they will receive or want to receive? And again, you find a strange discrepancy between the debates that people are having about how this information should be handled for the general population, but not a word about it when we regard expanded carrier screening for gamete donors. Now, an important point, and if you want already an indication of the points I've made above, is that there's a huge variety in screening panels. There's really a whole gamut of panels around commercially available that can be used by any clinic. And the first important point is that the screening panels are not limited to autosomal recessive disorders. In fact, they also include dominant, X-linked, and predispositions in the panel. And so, in addition, they include many conditions that do not fulfill the criteria that are proposed by the international societies. Now, we can have a discussion about the number of these, for instance, the one that was already mentioned about seriousness, but in fact, the fact that so many of them do not fulfill these criteria is already an indication that there might be other interests around. Now, what about the implications for the donor? First of all, with the current panels, you can see that a number of them are testing for late onset disorders. Are the donors aware of this? do they really understand what this means? They are being tested for genetic cancer predispositions. Again, you can very well understand why a recipient would want this, but what is the donor going to do with this kind of information? And for instance, there might be carriers who might develop problems later in life due to syndromes that are X-linked. So there are, in fact, also for the donor's own health, a lot of information that may have repercussions. Secondly, there's obviously that all the information, in fact, most of the information that is going to be obtained through the expanded carrier screening might also have an effect on the donor's own reproduction. So, for instance, the intermediate alleles for fragile X is one of the examples, but in fact, all genetic information might indirectly also have an implication for the donor. And then finally, this was also a remark that was made by the first speaker, there may be implications for the donor's genetic relatives. So genetic findings may have repercussions for first-degree relatives. So is the donor aware of this? Does he or she know that this question may come up as soon as he or she receives this information? Is someone going to help the donor to handle this kind of problem? It is at the moment completely unclear what kind of counseling is being performed on this specific question. Now, what can we do? I think that a very important part is that since donors are helping others, it is important to minimize harm to the donors. There's at least two things that can be done. First, no information should be collected from or shared with the donor that holds a high risk of negative effects. And secondly, the panels at least should follow the criteria for inclusion of the genetic conditions so that this kind of information should not be obtained. So I think what I'm asking for is that whenever a new proposal is being made regarding genetic screening, that one should also look at the position of the donor. Now, there's obviously a number of possible, let's say, possibilities regarding the way we can handle this in practice. And one of them could be that we introduce a kind of stepwise procedure where you would have 3 different steps. First, mandatory screening for a basic panel of recessive diseases. So I'm not against the screening, I'm just against the panel that is being composed in a number of cases. You could have recommended screening for X-linked diseases, which means that the donor should not agree and does not have to be tested in order to be accepted as a donor. And finally, you could have optional screening for selected diseases, which are included in the expanded panels. So again, if the donor him or herself is interested, this would be a way of finding out, and there would be no problem regarding the consent of the donor. So in conclusion, I think that it is important to start looking at donors as any other person to whom genetic testing is offered, and not just as providers of gametes. Expanded carrier screening should not be mandatory for donors, given the small genetic risk benefit, and because this small risk benefit does not outweigh the social and psychological burdens on the donor. Thank you.
Thank you very much, Guido, and that that sort of thought-provoking presentation on the sort of the ethical issues here leads us very nicely into the discussion. So if I can invite your fellow panelists, Zosia, Scott, and Véronique, to turn their cameras and their microphones back on. We've got several questions already to get our teeth into. Right, and don't forget you can continue to keep those questions coming. We've got half an hour, so I'm going to plow through as many as possible, and I'll the first question is directed at Scott, which is Scott, you're advocating expanded carrier screening for all rather than only on donors and recipients? Sorry, are you, do you want it to be wider than just donors and recipients? Should it be offered in the community and not limited to patients undergoing assisted conception? So I think if you answer that, Scott, first, and then perhaps we go to Zosia.
So I think that, that tonight's talk is all about that, and the whole set, lecture series is about donor, but you're right, that's just one end of it, where there's very clear responsibility on the IVF's unit and the state funder doing that. But you can then step back from that and say, is it all people having IVF? Because the same rules apply. And then actually, is it the same to anyone who is trying to conceive? And actually, in the US, they've already moved to that. I think that's, that's why Council 2016 had 350,000 people, because actually they're much more comfortable with genetics and they're accustomed to having that. And it comes back to that question is, could we prevent something? And could you do something different? And it's, for those of us who do genetic clinics, I think often that's the question that patients ask is, could we have done anything different? Or, for any clinical care that we have, could I do anything different? And the reality is, yes, we can. And so I think we might start at this very well-defined population, but with time, I don't think we'll be having debates in the future. I think it will just become routine because the economics will drive that. And it's economics, that actually at 1% reduction in risk, the costs, benefits are actually substantial associated with it, because the cost of lifelong medical care for many conditions is so profound.
So Zosia, do you want to add to that?
I think if I come at this from kind of wearing my day job hat as the person who's tasked with writing the bid that is trying to persuade the chief executives of Scottish health boards to increase the spending on genetics, and I've spent the last 3 years, I think, trying to prepare the way for more testing in NHS Scotland, and we are still struggling to get additional funding, not just to do, not to do genomes, because that's not even, there'll be a few genomes potentially on the table, but actually we're struggling to get the funding to test everyone with severe or profound learning disability. I hope we will get that one over the line, but it's still not a given. We do not have universal testing for carriers in any arena at the moment in the health service in Scotland. When I did my PhD, which was quite some time ago, I got the thing signed off in 1995, and in that I had 6 papers which went from the practicalities of cystic fibrosis carrier screening through to the health economic evaluation, and it had a lot of reflection on the personal views of being told the impact on an individual of being told you're a carrier and how people deal with that. And all of that was evaluated and brought together, sort of weighing up the not knowing versus the knowing costs and benefits and so on. And although the body of that PhD suggested that everyone thought it was a jolly good idea to offer carrier screening, it never happened. It never happened because I think largely the voice of the parent group, of the family groups at the National Screening Committee, was it was more important to invest in care than in prevention. So that has been the UK steer. And if you look at the 15 million or so we spent in Scotland on genetic testing at the moment, about half of that is spent on testing people's cancers to work out which treatment they should get for their cancer. And then everything else has to fit into the rest of that window. So we haven't had an uplift in that funding for quite some time. So I think the question for me is less of, is this a good idea? And I think we've heard the pros and the cons to it, but I feel the biggest, one of the big issues is where would this even fall in the pecking order, and where, even if this was made more widely available through personally driven testing, I feel that the struggle I have with it is that I feel you should be treating everybody equally. So if donors are going to be tested, I feel they should have their results. What psychological burden are you then putting on the donors, 1 in 4 of whom will be shown to be carriers of something, the vast majority of which will never have come across someone else with the same thing? And, you know, will that be at the back of their minds? You know, how is it to live with that? And is it right, is it fair that people who are having IVF or fertility assisted pregnancies should get a better service than the general population? If it's about the general population, it has to go in that pecking order of what should be funded. And at the moment, we can't get treatment-focused testing for colorectal cancer over the line. So I can't see it coming anytime soon, but lobby your MSP.
Thanks for that, Zosia. And you know, you sort of picked up on so many different issues there, and I suppose that always is one real tension in a publicly funded healthcare system, is the sort of prevention or avoidance of something, and the cost of, you know, and the resources that perhaps might not be there to currently to look after people who've got the condition at the moment adequately, and where do you find those tensions? I didn't know whether you wanted to come in on that, Véronique, and add something there about from your experience.
Yes, I would. Thank you very much indeed. I think, of course, it is a very, very delicate subject, and it makes me think back to an experience that I had in my early days at Chana, where a couple had gone through 5 rounds of IVF until they successfully conceived and gave birth to twins. And they discovered very, very soon after the birth of those twins, long awaited, much pain and suffering to get to the point of delivering those twins, that one of those babies was affected with cystic fibrosis. And neither of them were aware of the fact that they were carriers. And they found themselves in the joyful situation of becoming parents after all that travail to get to that point, and turned around and said, if only they'd understood, and if only the clinics had made it clear to them that this is something that they could have screened for, to know that they were carriers, and that there were procedures in place that they could have put in place to avoid it. And I think it picks up on really what Professor Nielsen said, is this something that we can avoid? Unfortunately, this whole sector isn't fair. It isn't about how funds are spent equally. We could talk all night about that, and about the fact that there are those that are being funded to have their fertility treatment, and there are those that are having to fund it themselves. It's something that really is a topic in its own right. But I do think that giving people the information about preconception screening, giving people the opportunity to know if they are carriers, especially in the setting where they are needing to use donor gametes. We have to be very clear that the donor gametes are being used by a very specific group of people. It's not the everyday scenario, and therefore I think the more information that we can arm these individuals with, and the choices that they can make and support them to do that, I think we're giving them what they need.
Okay, so Guido, you may want to come back on this, but there's a question that I think is perhaps for you that I'm going to put, and if you want to come back on the topic we've just been discussing, please do. But is it reasonable to expect donors to consent to screening and the potential disclosure of their genetic information if the genetically contributing parents are not being tested first? So if you want to sort of comment on that, and we'll perhaps then come to the other speakers.
Yes, well, I think that is a very reasonable point. For normally within ethics, reproductive ethics, you think that the primary obligation lies with the parents, I mean, with the intended parents. So if someone should be screened, it should be them. So, and what we see is that also when you have screened the donor, that doesn't necessarily mean that also the recipient is going to be screened. We see the same thing for partners. One of the partners is identified as a carrier, but that does not mean that the other partner is going to accept screening him or herself. So that makes the information, by the way, completely useless, because when you do not have the information on the second reproductive partner, you can't do much with with the information on recessive diseases. So I think that there might be ways of trying to handle this in a practical way, saying that people who do not want to be screened should not have the right to use a screened donor. That might be a way to handle this. But in reality, of course, it's going to be extremely difficult for clinics to handle all these different categories of donors. Now, I do want to come back to the point that was made earlier about the risks, because I find this indeed very, in a way, funny, because it is all the time mentioned. As I said in the beginning, when you do this properly, you will not gain 1%. So the risk reduction is going to be small. And then the question is this kind of attitude of trying to minimize risk, is this maintained during the whole process? And so what I am seeing, and I mentioned that earlier, is that, for instance, when you looked at egg donation, the multiple pregnancy rate of egg donation is around 30%. So you screen your donor to gain 1% in genetic risks, and then you create multiples at around 30%. So explain to me how the health of the offspring is going to be the main reason why you do this. So my suggestion would be, if you do this, then you have to do it all the way. And this is going to be very hard with such a small risk reduction. So I think, look again at why exactly we are doing this.
So, Scott, I'm guessing you're going to perhaps want to come back on that.
No, I think Zosia, I realised that Julio had that as the conclusion of his human reproduction paper that I would commend to the readers to have a look at as well. The reality is that we appreciate that, you know, multiple pregnancy is a risk, and that's why the HFEA, particularly in the UK, has targeted 10% as a target. In Scotland, we're down at 4%, and continue to reduce that further. So I think you're right. Guido, as part of risk mitigation, is not just that. Actually, when you think of the entire IVF process, so that applies to thinking about ovarian hyperstimulation, trying to reduce that risk, trying to reduce the multiple pregnancy risk, trying to reduce adverse pregnancy outcomes, and also then reduce adverse lifelong care, and requiring lifelong care for a chronic medical condition in the offspring. They're all part of that comprehensive risk mitigation strategy. And you're right, we can't just focus on one part of it. We need to do it across the entire board. And I think that's what, certainly with the Scottish Government's help, that's what we've been able to achieve in Scotland. I think we should be doing that.
Do any of the other panellists want to add anything on this point? If not, we'll move on to the next question. You're both staying mute. So well, we have a comment from Joyce Harper, but I'll try and think if there's a question because I think it's quite a good comment. So Joyce says, we've studied the main ESC panels and they're all totally different. They don't all test for the most common mutations. It's as if recessive diseases have been thrown in the air and each company has picked different ones. So I think there's a question there is, if we were to decide to go down this path, how would we alight on what I suppose we call the right panel, and how as a society do we, should that be a discussion for society, what is included in that panel? Because some people could argue this is going down a route where we are, it's sort of negative by association on people who are living with a disability. So where do we think we should go with that? And I don't know who wants to come back on that first.
So
do you want to go first, Scott?
It's absolutely correct. There is no standardization. If you look at all the different companies, they've got different platforms. And I think that's really kind of people like Zosia and Guido can interact with their colleagues across the world to say, this is the panel that we should be aiming for in terms of, and we can know, they know exactly what is severe, causes medical conditions, what's profound in terms of life impacts, and then they set a threshold. And we have to accept that there's going to be an arbitrary line in the sand, but actually that line, and that line can always be adjusted in the future. But that's kind of what we should be doing, is saying these are the key conditions, these are the variants that we associate with that, and then we move on. And I think that's what some panels have tried to do already, but perhaps not as well as it could do if they had taken a much wider population across the world, and it was an international agreement on that. I think that's the way to do it, not just one country, actually international agreement.
And Zosia, do you want to come in on that?
So I would just add that I think the lack of consistency is quite important, because I think it shows that it's not an easy thing to come up with. But then when I see a lack of consistency, it makes me feel uncomfortable that one condition is being valued over another. Where I struggle a little with this, we have a list of conditions in the HFEA set out that are approved for PGD, and that list has changed over time. And in clinical practice, we found that, you know, often for a family, the influence of the decision is very much based upon personal experience. So some families who have a child with cystic fibrosis do not want to have testing in a further pregnancy. In fact, many of them don't. There are many examples of conditions where parents choose not to do testing because they don't want to, you know, they'll kind of take what they get. They don't want to sacrifice an unborn life for that particular condition. And you know, once you get into the fertility arena, then, you know, the more things you're testing for, if you have PGD, particularly in somebody who's maybe a bit older, you may not have as many embryos to even select from as an example Scott gave. So you know, this lack of concordance, I feel, is a concern. I think if there is going to be a list, it should be at least a nationally coordinated list, and it should include members of the public. It should include ethicists. It should include people who understand about the conditions. And when I say members of the public, I suppose I also mean patients who, you know, see things, you know, who actually know a bit more about it. And I think that's, you know, just to put that list together is going to be very challenging. I think, you know, something just to add in is that, you know, when the 100,000 Genomes Project was conceived, the idea was that everyone who had their genome sequence would get feedback on kind of what they were carriers of. Now, that was very soon narrowed down to just being a carrier of 2 preconception conditions. I think, or did it just focus on sickle cell? I can't remember if it included sickle cell. It certainly was just focusing on cystic fibrosis. Those results haven't even come back because of the complexity of actually giving out those results, and it's not been prioritized given the main goals of the project. So just the effort, you know, the efforts involved to do this well, I think are, you know, really challenging when there's so much else going on. So I don't know if that helps.
Yeah, I think it's interesting, you know, the sort of parallel you've drawn with the to PGD or PGTM, as I keep trying to tell myself to call it. And I know that Genetic Alliance UK often, well, I think nearly always, actually provide the regulator, the HFEA, with information from the patient groups about the lived experience, so that the, you know, that sort of that chance, the chance of something, as well as the burden component of a genetic condition on the family and on the child, are all taken into account. So I think I'm going to move on to the next question, unless anyone else is desperate to chip in. Wave your hand if you are. So we have a question from Raj Mithor, and I suppose this sort of ties on, follows on from that last question, because he wants to know, how do we decide which conditions are included in the panel? But then he goes on to develop that into saying that many would feel uneasy about polygenic risk scores, something that we're always talking about in the PET office. Doesn't the logic of the ESC-based eugenics lead inescapably to just that? So I don't know who wants to go with that first, but with the mention of the word eugenics, I'm perhaps looking at the bioethicist on the panel at Guido. So do you want to chip in first on that?
Well, I think it just confirms what I said earlier about the fact that you need criteria. If you go, I mean, we're going to be able, and it's going to happen sooner than we might think, but we're going to be able to test for a multitude of things. for the polygenics, but everything connected to predispositions. I mean, you will have indications of 10% more chance of having Alzheimer's and 15% of having diabetes and whatever. So what exactly are you going to do with the information? So the clinical utility will be a very important one. And that combined obviously with the enormous amount of information. Who is going to handle this? I mean, not just for yourself, but also the next step if you move, for instance, to pre-implantation genetic testing. So I think that one way or the other, rather than collecting more information as we see now, we have to decide which information we want. I mean, obviously, technically speaking, we may be able to gather an awful lot of information. The question then is this going to increase the autonomy of the patients? And that is a very real question. It's not just a matter of eugenics. I mean, you might have very good reasons to be selecting. The point is that we just have to be reasonable about which things we are looking for. So I think that this is a very important element of the whole debate. And I think that to a large extent, what we see now is that the whole evolution is pushed by the technological possibilities rather than by considerations from a policy or an ethical level.
So Scott, do you want to come in on that, and then perhaps Véronique?
Yeah, so I think, you know, in terms of how we decide the panel, I think, as you say, it's a multidisciplinary stakeholder panel. That's how you would do that in an international setting. And that needs to reflect different ethnicities and different, you know, groups and large cohorts that can be established. So I think that's the way to do it. In terms of the polygenic risk scores, I know Nathan Treff, you know, and I think his company called Genomic Prediction, you know, had a paper earlier this summer looking at that in terms of using the UK Biobank data and trying to suggest that it was possible to reduce type 1 diabetes, for example, although the person, you know, is using other examples for depression. I think there's lots of questions about the performance of these polygenic risk scores. I think I'm always conscious of Marcus Manafo's writing and George David Smith's on polygenic risk scores and others. They're not so good, you know, so I think we're not quite there. What we're trying to probably say is let's focus on things where we have a, you know, a tangible, you know, disease phenotype, and I say it's going to be a limited number that a multidisciplinary, you know, panel with patients and so on will come up with, you know, and then we can implement that.
Okay, Véronique.
Thank you. Yes, I think I really just want to add to that something that just because you can doesn't mean you should. And I think that, you know, I had the privilege of being involved with the Human Genome Mapping Project all those years ago, and it was all terribly exciting, and you felt like you were doing something really quite important for mankind. And now I look around and I see, you know, the online kits and people can go and have their ancestry traced and all that kind of thing. And I hold my head in my hands thinking, you know, we kind of let a really dangerous genie out of a box in a way. And of course, so much of this information has helped us to use the information wisely to cure diseases and to have a better understanding and to avoid the risks. But I think that really careful consideration of what is included in these panels, not just including small populations and small groupings like our own Jewish population, but we've seen so many small groups that have managed to successfully eradicate diseases, but the considerations have to be taken very, very carefully, including, as you said, a multidisciplinary stakeholder approach, and also just really exercising caution on the implications of people having this information. As Professor Guido said, how much information is this going to generate? It's not just for keeping the bioinformatics people busy with all the data that's being generated. It's about what this actually, the impact it's going to have on the lives of the people that get this information, and getting their heads around it. It's can for some really, really be quite tricky. And I think that that has to be thought through carefully as well, and putting the implications, counselling and all of that into play ahead of time is really very important.
And I think one of the things that's come up in the questions and the comments quite a bit is, you know, comments about genetic counselling. And I think that is an area perhaps where we're I think Zosia might be best placed to comment on this. I don't know what the availability of genetic counselling is like, but my understanding from our work with Genomics England is that it's actually, there aren't that many of them, and so they're quite a pressed already resource. And so with this, Zosia, do you think there is the capacity if we sort of scaled up with
so
these sorts of tests?
There's already huge pressure on genetic services, and our waiting lists are going up. The more genomic tests that are done, the more fancy tests that are adopted. We're being asked to do testing in a wide range of arenas, and more and more people are asking for help. And even when you make genetic tests available to doctors in the mainstream, they come to us with the question. So whether it's genetics counsellors, whether it's the doctors, yes, there's a huge pressure on the resource. We haven't been training enough of them, and lots of them are about to retire. So yes, there is an issue there. And even if we try and change the skill mix going forwards and have maybe different tiers of expertise with sort of basic level counsellors and then genetic counsellors or whatever, it's still a scarce resource.
Okay, so I'm going to take one more question. I think let's see how we go. If there's time, I'll squeeze in another one, and that is from Michael Thomas. I'm going to not quite. I've got a bit. Are there grounds now or in the future for screening of gamete donors or embryos based on common variants for continuous traits such as IQ, there are lots of arguments about whether IQ is really a thing, or height, or again where polygenic scores can now predict some proportion of outcome? Or would the speaker's view be that as of outer bounds, that's out of bounds perhaps too open to commercial pressures? And I suppose, there could be a bit of a slippery slope here, as if we start on some of these things that are a bit more, lifestyle, height, then where do we go with looks and the usual things of, blue eyes and those sorts of things? Are we opening another Pandora's box here? So, Zosia, do you want to come back first on that, and then we'll go to each of you in turn?
Sorry, could you repeat the specific bit of the question? Because
Yep. So are there grounds now or in the future for screening of gamete donors or embryos based on common variants for continuous traits such as IQ or height, where polygenic scores can now predict some proportion of outcome? Or would the speakers view that as being out of bounds, perhaps too open to commercial pressures?
Personally, I'm struggling enough with the recessive concept. I think selecting on the base of continuous traits would be actually as effectively being done by taking a history and or just looking at the donor and saying, are you tall, are you small, are you intelligent, are you not? I'm not convinced that polygenic traits as they are at this moment will give additional information that is more predictive than that. But I'm not sure it's my area of expertise either.
Okay. So Guido, do you want to come in on the ethical angle for that?
Yes, in fact, I agree with Zosia. If you look now, depending on the country, in Belgium, for instance, you're not allowed to do any choosing of a donor. So there's no catalog to look from. But in fact, when you look at most international banks, you're free to look at whatever, baby pictures and all kinds of information on study results, other things that might indicate intelligence. And normally you expect any clinic to make a certain selection among the donors so that you have, let's say, a normal man or woman that is going to be a candidate for donation. So I don't think that your genetic testing will give you any additional information apart from the one that you already have. And by the way, there is already an acceptance in a certain way because most countries allow donor matching. So that means that you are allowed to choose on the basis of the correspondence with your own partner. So in terms of height, in terms of, well, intelligence would be quite difficult, in fact, to know, but I don't think this is going to add much more. What you see is that indeed the number of clinics at the moment are offering this, But I really wonder whether this is working. I don't believe it for a second, to be honest, but obviously it's the same thing as you have now. Commercial banks and commercial clinics are trying to attract as many customers as possible. So if you offer a service that patients want, whether it be additional screening or whether it be screening for specific characteristics, some people will find that attractive and will go to that particular clinic. I don't think there's any good reason to accept it, but I think this is the reality we have to live with.
So, Scott, is there anything you want to say? Because we're going to be closing the event very shortly, so I'll give you a
sorry. So I'd read Michael's question, so that's really what I was talking about with Nathan Treff. So, and Genomic Prediction is his company. So he's the one who's been pioneering this concept of what he's called PGTP. So we're P for polygenic, and so pre-implantation genetic testing for polygenic disorders. But rather than, you know, things like height, as you say, that you could ask, but you can obviously see from the donor, what he focused on when he presented the mathematical possibility of it was type 1 diabetes, and said, okay, you can get like a 45 to 70% reduction in type 1 diabetes by using a polygenic risk score. I'm not sure that others have been able to show the same performance actually in terms of reality, because you think of the combinations you've got, the limited number of embryos that are available. That's where the real issue is. So I think we're quite far away from using a polygenic risk score in any meaningful way. And I think we should try and focus on tangible things, as we've been saying, that have got autosomal recessive being the first one before we even think about polygenics.
And Véronique, I don't want to start to close the event without allowing you to. So you have the final word from the panel.
Oh, that is very generous. Thank you very much. I think really, I do feel, as we've said before, it doesn't mean because you can, you should. And I think that really looking at the ethics is very, very important. And don't disregard the nurture side of things as well as nature, that you can't screen for everything. And we know what we know today, but further down the line, these couples may have gone through extensive screening of their donors and discover all sorts of other things later on down the line. And I think that that has to be borne in mind, and the support that is needed to go wrap around that for the donors, for the users of the donor material, and also not to forget the donor conceived child at the end of all of this, further down the line, even if it's many years down the line, that they have to be taken into consideration as well. And it may not be popular, but the emotional support that is needed for everybody involved in this should not be underestimated as well, and therefore really careful consideration should be taken.